Oh. You know what people in our business really bother me?
Well, there's a lot of them, but go ahead. Tell me which
People who
population.
have a social media presence, but that have no platform other than posting pictures of them in a flight suit, helicopter, chest rig. I was scrolling Instagram and I was seeing pictures of people that were posting, just shit in the helicopter with their chest rig on. Look at me. I'm a flight medic or I'm a flight nurse. And it's a cool job. I love my job, obviously, and you
Yeah.
do too, because we do what we do. But I think it's kind of like being a hospitalist. It is an accomplishment. It is a cool job. Takes a lot of work to get to. But at the end of the day, the general public isn't impressed by it. Like, you're not going to woo anyone by going, hey, I'm a hospitalist. I don't know. Maybe I'm just too negative, but I just think that people who look at me, I do flight, and it's the only crutch they have to stand on. I don't know. I'm just thinking out loud.
I kind of feel like the opposite is true. I feel like people are like, "Oh my
Of course you
goodness,
do.
a flight nurse, a flight medic," and I'm like, "No, no, it's not nearly as cool as you think it is." I think it's cool. I like having this job, but I think people think it's more noble and heroic than it really is.
Yeah. Yep. All right. So speaking of flight, I'm a paramedic. You're a nurse.
Hmm.
There is an article in the most recent edition of the Air Medical Journal. I like the Air Medical Journal. It's fine. There are some articles in there, though, that it's like you just want to get published. And it's like comparing intubation stats among physicians responding using HEMS uh, dual engine aircraft in the fjords in Norway. And it's what the hell does that mean? Anyway, my old medical director used to tell me that I should publish stuff in the Air Medical Journal, and then he would jokingly say, because they will publish anything anybody submits to them. I don't know if that's true. Do you have any
Well, you should
insight?
try it. You should try to publish
I know
something.
I
There
should.
was a study. I wish I had some kind of connection with an academic institution who could facilitate me doing studying, because for years I have wanted to do a study where you just take like a fourth grade math, those worksheets that you used to get that, like, you get 60 seconds to do as many of those quick math facts problems as possible. And then beep, the
Yeah.
timer goes off. And like, I, you know, stuck. What's the past tense of steak? I'm really tired. I based my entire worth as a child based on whether or not I could finish those math facts worksheets in under 60 seconds. Anyway, um, I really need sleep this week. I haven't slept a whole lot. Um, Taking those and giving them to someone at the beginning, hence, I feel a little bit crazy right now. Give it to somebody when they're well rested at the beginning of a 24-hour shift as a baseline, and then give it to them again at the end of a 24-hour shift, and just do it with, like, a couple thousand people and see what the scores you get. See how many you're able to answer in 60 seconds and how many you get correct. I think that would be a cool
It,
study.
it would. If I had to do that, not only would I probably be fired from being a paramedic, but they would put me in an institution and make me wear a helmet for the rest of my life. I'm still the guy who, on $100 dinner, I'm there using my fingers to calculate the tip. All right. But back, all right, Air Medical Journal. This was by Gregory Thompson Dio, Blake Miller, MS3. I'm guessing that's not a version of the Mara Salvatrucha gang. I'm thinking
Med
he's a
student
third year
year
medical
3.
student.
You ding
Yeah.
dong.
That's the MS-13. And then Timothy Lentz with a whole bunch of post nominals. All right. And this is called Comparing Intubation Success Between Flight Nurses and Flight Paramedics in Helicopter Emergency Medical Services. And they did chart reviews of 5,451 records. Now, limitation, it was only one program. It was just this one program in Wisconsin. And of those 5,451 records, they looked at all records with an intubation attempt. and they looked at it both per attempt and per patient. So they got 374 reports where there was an ETI attempt performed. And of those, 322 met inclusion criteria. 52 cases were excluded. 8 of them were because they used a supraglottic airway first line, which, I can't fault them. There are cases certainly where I've looked and been like, woo, just put a supraglottic in, mostly in codes, but whatever. And then there was one where they went first line to a crike. Do you remember you posted something about crikes and somebody commented, another social media presence person who
Yes,
does
yes, yes. Yeah,
education,
it was a list of like all of your airway.
snidely commented, I can't think of any scenario when you would go right to a crike first line.
Yeah, I've had one that we considered.
That screams big on knowledge and little on experience.
Yeah, I think you're probably right about that. Yeah, oof. I'm not going to tell the story of a case that we should not have even tried to intubate. We should have just jumped to a crike. It was so bad. Oh.
Yeah, there are times when you would go first line for a crike. I mean, no doubt about it. All right. So, of the 322 that met inclusion criteria, they had a 94.1% overall intubation success of patients that they tried to intubate. It doesn't mean 94.1 first pass success rate. All right, yes.
So one of the limitations is they didn't even define success. There was no metric identified in the study that said success. They didn't say how they defined success, and they did not look at how tubes were verified. So there could have been some of these tubes that were bad tubes, but there would be no way to show it in the data because they didn't include how the ET tube placement was verified or what defined success.
All right, very fair point. There were some bare bones stuff in this article, no doubt about it. What I'm taking for a successful intubation, and I could be wrong, but I'm saying they decided to intubate a patient, they went through the process, and it resulted in the patient being intubated. Whether that meant that they got the tube and it was easy peasy, lickety split, off you go, or whether it was we had to try 14 times and the patient crashed and burned, but ended up with an ET tube between their cords. I think that's what they're defining as success.
Yeah.
But I could be wrong. You raise a very good point. So overall success, 94.1%. 89.4% of those successful intubations were performed by a paramedic, and the remaining 11.5, I know that's missing 0.1%, were performed by an RN.
So I had a couple of thoughts when I was reading over it. I thought, number one, this could just speak to this company having a terrible education approach to teaching nurses. So their very rationale was medics get more tubes than nurses because medics have been intubating their whole career, whereas nurses, before we come to HEMS, we have no reason to intubate. We all work in the hospital where a physician or an RT will intubate. Maybe it just means that they don't do a great job of teaching their nurses to intubate. When I first started flying, I was flying with a very large, I'm sure everyone would know it if I said it, company that provided us with like a 10-day training. And I had never intubated. I'd never even practiced it on a mannequin before I came to that company. And I felt like they adequately prepared me to do that in the field. The second flight company that I flew with provided no education whatsoever. Had I not flown with another company before, I would have been completely inadequately prepared to intubate in the field. As well, I felt like a flaw with this study is they talked about how I took some notes on this. It was a flawed logic that all medics routinely, was the word they use, perform intubations. So where I fly at now, my current flight job, I actually really love this job because of all the clinical opportunities we get. We're required to spend at least one day and get 8 to 10 tubes in the OR. We get to go spend clinical time in the NICU, PICU, MICU, CVICU, trauma ICU, doing procedures. Our medical director works in the ER and will routinely call us down to do intubations or cool procedures, chest tubes, whatever. But are the ground service that feeds into our air service, they're not allowed to intubate. So we just hired a crop of medics in our last hiring class that some of the medics had never intubated other than paramedic school and OR time. So that's a limitation based on this study only looking at their own service. They even talk about that in their own limitations that, it was only their own service. It was that one region, there in Wisconsin and a Scotia bit into the northern part of Illinois, that not all places do have ground medics intubating. So sometimes our medics are coming to us with no intubation experience. And so now it's both of them who have a lack of experience.
Yeah, that's a good point. It tends to be on my team that the medic takes the airway. It's not a written rule or anything. It just happens to. It's kind of the old thought that we work as a team, we do the same job, but on the inner facilities, the nurse is doing the lead, and on the scenes, the medic's doing the lead. Now, as the nurses get more experience, it all kind of blends together on scenes.
Mm-hmm.
But me personally, the nurse is doing the friggin' tube. I've got enough tubes. I get enough tubes a year working as what I call a real paramedic on the ground. So unless it is, I don't know, a 9-month pregnant woman aspirating with third-degree burns, where the most experienced intubators should be doing the tube, like, hell no, the nurse is doing the friggin' tube. We had a guy, I did a podcast on it, waffled by a car, totally fucked up airway. We actually were talking afterwards. We could have, and we would have totally been justified to just crank him right off the bat. I said to the nurse, I was like, do you want the tube? He's like, do you mind? It's a bloody traumatic airway, though. Good. You need to do this. I've done this 100 times before.
And that's what makes you a good partner and a good preceptor and a good teacher. That's where it is at the flight service.
It doesn't fuck up my stats. If the tube gets missed, it's not my stats that are getting messed up.
Right. Okay. Only paramedics keep a hold of their stats on their tube rates.
That is true.
I know.
If you actually compared ER doctors, like, they don't track their tubes. I asked 5 different ER doctors whether they track their tubes or not, and this was from around the country. It places from, I asked Sush Prusty. He was very honest about it. He said straight up, no, but it should be tracked. Another said, I track it if it is a deleterious attempt. In essence, if something goes wrong, then I document the missed attempt. Otherwise, if it took me 2 attempts and nothing bad happens, they don't document it. Another said yes, and then I got a no, and then some do, some don't. So I really think that if you tracked ER doctors' innovations like you track ours, and you didn't just look at services in big cities where, no offense, you have firefighters who have no desire to be a paramedic or keep up their cert, but they do for the job and the premium pay, and they wouldn't know the difference between a laryngoscope and a can of skull. You can't look at a service like that and analyze how good paramedics are at intubation and apply that to all. I think if you really did a widespread study, you would see that probably equal.
Yeah. So they did say in the limitations of this article, and I do really appreciate them considering this cultural kind of component of this. They said the direct quote was, this program's mentality was that, quote, the medic owned the airway. And I can tell you right now, that is a flight service I do not want to be a part of. If it's a bunch of cocky guys who won't let someone else. And look, I'm never going to fight anybody for a tube. I'm always going to let the medics do it. And maybe this is flawed logic on my part, but I'm always like, number one, it's not my favorite thing to do. I put a ton of pressure on myself and I get a little bit I have a baseline tremor anyway. My brother and I both do. He's a fire medic as well, but he's actually a decent guy. Sorry to all you fire medics out there. Anyway, I'm actually not sorry at all. I don't love intubating. It's not my favorite procedure. There are other procedures that, yes, I will roundhouse you and knock you out so that I can have that procedure, but intubating isn't one of them because you guys are so much better. I love doing chest tubes and finger thoracostomies. I love them. They're so satisfying. Right. Anyway, that's besides the point. That's my favorite. Or a good EJ. Oh, there's nothing more Eva, my 6-year-old, she was screaming today at the slide park, and her little EJ was popping out, and I was like, gosh, it's been a good month or two since I've popped a 16 into an EJ, but man, those are sad. Anyway, I'm chasing a rabbit here. I don't want to be part of a program where it's this skill or this duty always belongs to the nurse and this one always belongs to the medic. Like, I really love when there's a healthy team dynamic and it's like, you know, I've noticed my partner's really tired today or they're grumpy or something. I'm just going to knock out the whole chart on our return flight home. And when we get home, they'll be pleasantly surprised they don't have to contribute to the chart. Or, you know, I just like it when we can each cover each other and, you know, just kind of shift responsibilities and roles and everybody can sit both seats. And
let's look at first pass success in this. 86% overall first pass success, which is pretty good. But you also have to consider you know, we're all guilty of this in EMS services.
Lying on your chart.
You know, I would never lie on my chart.
I don't believe you.
You know those hot messes? I remember this one guy, catastrophic upper GI bleed. He is so hardcore dying. There is literally blood dripping off the rails of the bed. There's 2 suction canisters full of blood. The bed is saturated in coffee ground emesis. He's got an A-line pressure of 40 with a very dampened waveform. And I remember I talked about this once on a reel I did. I asked the doctor in the ICU, have you given him any blood? And he said no, because his hemoglobin, his H&H are good. I'm like, they're all over the fucking floor. His H&H is everywhere.
I've been so surprised with doctors. Look, I'm never surprised when it's like, you know, a nurse or a medic, because I mean, heck, before I came to flight, I didn't know all of those things that are critical care level. I didn't know that a hemoglobin in an actively bleeding patient wasn't accurate, but I know now, and I expect for physicians to know. And I cannot tell you the number of times I've said, hey, do you think maybe we could give some blood? And they're like, no, their hemoglobin's 13. And I'm like, there's a clot the size of an IHOP pancake on the floor.
Yeah. One of my followers reached out to me. It wasn't about bleeding. It was about Cushing's triad. And he said that he was talking to the doctor and he was like, well, his patient's intracranial pressure is elevated. They fell or whatever trauma. And their heart rate was in the 50s. They're hypertensive. The patient was confused. And the doctor told him, no, there's no intracranial pressure because Cushing's triad has 3 parts and there's no respiratory pattern changes. It's like, motherfucker, they're unconscious by the time they have the respiratory pattern changes.
You know, sometimes I think like this person, they're being legalistic about it, right? And they're not realizing the why we see those changes. That's because the brain is squishing down on the medulla. Like, think about why we see those changes. Like, never mind. Sorry, we're chasing a lot.
Sometimes I go to these interfacility flights and it's almost like I want to look around and say, am I on an episode of Punk'd right now? What is happening? Like the time I had a respiratory therapist tell me they had a child, a 12-year-old, with a tidal volume of 750. I said, why do you have this guy on a tidal volume of 750 mLs? And those of you who don't do critical care transport, that's fucking huge. That's
the only person who can hear.
That's like a pit bull fucking a chihuahua when it comes to tidal volumes. And this respiratory therapist told me that it's to compensate for the dead to. Oh, I'm sorry, I forgot your son was there. He tells me it's to compensate for the dead space in the vent circuit.
Was he using a 5-inch like hose that you hook up to the?
I don't know.
What do you call those red things? What are those things that the firefighters hook their hoses up to? What that thing is called? Hydrant? Yes, the fire hydrant. Was using that for an ET tube circuit? Golly.
Yeah,
guys, you do not. If you don't do critical care, you do not need 750 mils of air to compensate for your dead space.
No.
One of the things that they were talking about was looking at the Malampati and the Cormac airway grade scores. To which I wanted to say the anesthesia department called and they want their assessment scales back. Who is doing these? Who is doing these in emergent RSI situations? And why would they use that as a metric?
I'll be the one in every crowd commenter who goes, actually, on our last 12 intubations in my flight service, we asked the patient to do a Malin potty every time.
Oh,
No,
your
I'm
patient
fucking
that shot
kidding. No,
themselves in the
nobody
face?
does that.
I know. That's my
No,
point. It's like,
nobody.
why would they collect that data and not the data on, okay,
And
this we are marking success when you had, adequate waveform capnography, and then it was furthermore, it was confirmed at the receiving hospital via whatever.
that's why they now have the Haven criteria or Heaven. I always say it wrong because it's more applicable to what we do. Malin
Absolutely.
potty works if you're a crackhead with bad teeth who's getting a boob job and you've been NPO for 12 hours.
Yeah,
And
yeah.
the nurse anesthetist comes in and goes, can you say, ah? Like, oh, I see you have bad teeth and a big tongue. You must snore, but okay, let me write that on the form here.
Yeah, I was doing some consulting work yesterday with a flight service in Canada. Asked me to review their CQI forms for intubations because they're just introducing intubations. It's different than they do here in America. It sounded like they have like BLS flight services, ALS, and critical care. So they're currently moving up and introducing intubations. And that was some of the data that they were collecting was the Malampati score. And I said, hey, you don't need that here. You need to, and they had never heard of the Heaven criteria. So I sent them the literature on it. It's much more applicable to our settings of practice.
Yeah, the old 332 assessment where you'd have to slip a shocker into their mouth to check and see if you could fit a laryngoscope in there. I'm sorry, I'm tired. I get like this when
I
I'm
almost think
tired.
that you save your most audacious things to say in front of me because you just think it's hilarious to like watch me blush or to like. Also, the N
This
number
getting
was
off
only.
topic again.
We are chasing a lot of rabbits. So bringing it back, the N number was only 303 after they eliminated all the patients that had like multiple attempts or the ones who were intubated by the residents that occasionally fly with them. I wanted to look up the data. I didn't have time because I was reviewing this article and taking notes when I was in the truck with my mom and my girls on the way home from the slide park today. We were in Illinois visiting my family for Christmas, but I wanted to find what is a generally accepted N number. And me, just personally, and I have very little experience in research or academia, I don't really take anything seriously until the N number is above 1,000. What are you smirking about?
Yes, but you gotta do your statistical analysis. And I have written down here, I can't believe I'm saying this. They had in here that their statistics, they used that P was less than 0.03. And that is after your whole statistical analysis. And I'm not going to go into it because I bullshitted all of that through grad school. And it just goes to show that any moron can get a degree because I remember just blindly writing like, yeah, I didn't do any of this calculation shit. Like, I'm like, yeah, I did a logistical regression and P was less than 0. And they never checked it. They were just like, oh, okay. Like, yeah. I'm like, thank God they didn't look at it because I didn't cheat. I just was like the equivalent of, C. But anyway, I do remember that the lower the p-value, the less percent that it is due to chance. So if p was less than 0.5, well, that doesn't mean jack shit as far as your numbers or your n or your data, because that would mean that there's a 50% chance that what you found is due to chance. But
Yeah.
this was p is less than 0.03, so less than a 3% chance, I keep saying chance, that their data that they found is due to like random probability and randomness. So that is statistically significant.
Okay, I'll get on board with that.
God, I sounded huge there. I do think it was skewed. You talked about the N number. I do think that you could argue that I don't have the exact numbers written down here, but I mean basically like 90% were attempted by a paramedic. of the all the overall airways. And it's like, okay, well, if your nurses aren't doing that, if you're doing that skill 303 times in, what was it, like a
5-year period,
5-year
and they do 900
period,
flights a year.
that's not a ton of tubes. And
Right.
if the paramedic is doing most of them, then that's shit opportunity for the nurse to practice the skill.
Yeah. How many of the medics in
So I
your
do
flight
think
service also work ground?
In my service,
Mhm.
all of them.
Yeah. So they get
All of
opportunities
them.
to do tubes on the ground. How many
Sure.
tubes do you do a year, would you say?
I did close to 30 last year.
Yeah. I haven't done one since my OR day, like 4 months ago. I did 8 in a day,
Well,
but other than that, I
that's
haven't done
another
one.
that was another thing I thought about on my old team. And I had a great team. My old team, I would talk about, was, personality and leadership wise, a toxic environment. But clinically, we were fucking good. We had our
Yeah.
shit down pat. Excellent training. As far as the medical director and associate medical director, the best physicians I have ever worked under. Just amazing. And we got the same airway training that the ER residents get. We went through the same courses. We went through the same critical care training that the nurse interns that were hired in the ICUs out of nursing school got. It was really, really good. That
Yep.
being said, once you got past the initial onboarding and the continuing education, a lot of the airway training was done by the airway committee. And there were a bunch of nurses on it. And this team only did interfacilities, very maybe under 20 scene flights a year. What we did was interfacility transport, bread and butter. You give us an ECMO patient on 10,000 drips, best in the business, we'll take that patient. Scenes, we just didn't do. So you had nurses that have not done a tube on a live human in probably 15 years since they went through orientation, that were on this airway committee helping out with the education. I mean, that screams charlatan. That's like the people who teach the pre-hospital POCUS course and have never used an ultrasound on a real patient.
At the end, what they put kind of as their conclusion was flight nurses may benefit from more procedural experience in intubation as part of the flight training and continuing education to close the gap between their paramedic counterparts. And to that, I say, we all need more practice and more procedural experience in intubation, because I don't think any one of us, unless you're working like my bestie, she flies at a very busy flight service. They only do 12-hour shifts because they average 3 flights per 12-hour shift. They're just super busy. She gets tubes all the time. I don't see that high volume where I fly at. I don't have that much opportunity. So per CAMES, we're all supposed to do 5 per quarter, 5 adult, 5 ped, 5 neo. However, we all just do those.
Where the
on the
fuck are you
airways.
going to get 5 neonatal tubes?
I guess if you work on a neonatal transport team. I have never intubated a neonate. I think I'd sooner shit my pants.
Yeah, but you're right. The conclusion that says, and this isn't me poking, but I liked this article a lot. There are limitations. They're very upfront with the limitations.
Yeah.
I think they did a good job. It was really interesting, for one team to analyze themselves like this and then publish it. I think is a very professional thing. I think it's great. And I think that more people need to be like that, because we know that a lot of people sweep things under the rug. But this was a good article, I thought. But in general, these conclusions kill me. Like they always say, more research is needed. These people, and I know research nerds, blah, blah, blah. Dave Pfeiffer would get very upset and say I'm ignorant for me saying this. But I have one more master's degree than he does. So I can opine on this and say that all these conclusions say more research is needed. It seems like it's I would like to see a conclusion sometime that says we're pretty fucking sure that this is the way it is, and come at us and challenge us. You just don't see that. But not everyone's a bull in a china shop. But also the things like you said, the results show that nurses need more opportunity for training in intubation. As Norm Macdonald used to say on Saturday Night Live when he would do the fake news, like this and other groundbreaking stories from the medical journal, duh.
Yeah. Yeah. I think maybe one of the things that it says about our industry is number one, people just love to stir up the pot, and nobody's quicker to get
No. Me?
nobody's quicker to get bent out of shape than a nurse. Like with the Rodonda Vaughn case, look how many nurses were like, it wasn't her fault. You know.
Oh my God. And then when we have paramedics like the ones in Colorado and in Springfield, Illinois, kill somebody, we're all like with pitchforks, like, yeah, fuck them, drum them out of the profession.
Yeah.
It was their 12th call of the day.
Yeah, I think that we all need to be a little bit more open to criticizing ourselves
And the
instead of others.
lactation room doesn't even have a Zen garden.
When you were talking about the nurses being on the airway committee earlier, I was about to say, I didn't want to interrupt you because of the lag. It wouldn't have timed right, but shoot, nobody will join a committee. Nobody loves a committee more than a bunch of nurses.
Oh my God. I made a joke about that today. We had flown in our pedestrian struck, and we're on the rooftop. Another helicopter comes in with, this train wreck little kid that was another pedestrian struck from another incident. And we helped them turn the kid over, and I'm helping them clean their equipment. And they had this giant reusable, washable, like moving mat, but heavy blanket. And I've never seen it before. I said, what is this? They're like, it's our pediatric rat blanket. We can move them and wrap them up and papoose them. It's great. And my partner and I were like, our team needs this. This thing's great. And then I said, but they will say we need to form a committee to find out the best way to implement this. Here's a true story. When I was the operations manager on the flight and ground team in a past life, and as you all know, I hated that, and I went back to being a grunt. We got CMAX. We rolled out the training. We did a great job with the training. I think we spent $250,000 on CMAX for the air and ground team. It was a big deal. It got held up by the hospital service because the cleaning solution per OSHA required industrial hoods, so that you could have appropriate aeration. And my response was, we'll come to the hangar and we can open the garage door. And if that's not appropriate, like space for air to flow, then I don't know what is. So the committee determined that wasn't appropriate, and they were on hold. These things were in storage for a year and a half because this committee held them. Do you know how they got implemented?
What'd they do?
My boss had surgery, and the assistant nurse manager took vacation, so I was in charge for like 24 hours, and I put them all on the helicopters and the ground trucks. And I didn't put out an email about it. I told the crews, they're on the trucks, use them. They're still there. I bet the environmental committee does not know they're there.